It is the top of the hour and we like to get started on time. I want to make sure you can hear me. Okay, thank you. So I know many of you know Rochelle and the information she shares with us every month. But for our new folks, I would like to go through our introduction really quickly. I want to welcome everybody to the webinar today. I am Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us for the HTRC education series focused on telehealth billing, coding, and policy. A couple of things to remember. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted, so please unmute or use the chat to talk. Typically, it's easiest if we use the chat. I will be monitoring that, and I can let Rochelle know when questions come in, simply because we have so much content. We have to kind of move quickly through it. Your completion certificates will be emailed. It's important to sign on with your first and last name so we can identify you. You can rename yourself by using the 3 dots on your Zoom screen if your full name isn't visible. You can also pop it in the chat directly to me and I can note it as well. So let's get started. I would like to introduce Rochelle Marding. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Rochelle with us today to talk about rural health centers, telehealth coding, billing, and we may have just a brief public health emergency extension review as well. Now I will turn it over to Rochelle.
Yes, thanks, Molly. And I will talk a little bit about the upcoming date that we all have been watching on the public health emergency too. So for today's session for rural health centers, in talking about telehealth and an RHC, we're going to kind of start with, I always have to break this, or right now we're having to break this into kind of 3 buckets of time, all measured with the COVID PHE as kind of the focal point. So talk about traditional Medicare telehealth rules for RHCs prior to the COVID public health emergency. So what things are or were in that normal environment under a normal Social Security Act benefit structure for RHCs. We'll kind of shift and talk about what flexibilities were made available to RHCs within the public health emergency to deliver the telehealth benefit, but also some other non-face-to-face, I kind of refer to them as quasi-telehealth because they pertain to services that are not necessarily face-to-face with the patients in the RHC, but they also don't fall under the telehealth benefit, yet they do kind of relate to the concept of telehealth. So we'll talk about those that have been made available to RHCs during the public health emergency. And then, knock on wood, as we are hopefully at some point in the future nearing the end of the federal public health emergency declaration, we want to talk about what things might look like at that time once the federal public health emergency expires or is rescinded at some point in the future. And we'll talk about some important dates with respect to the PHE as well. So let me start with this first bucket in time. The first thing I think of when I say that is like the land before time. Like it's hard to even remember what it was like prior to COVID. But these were our rules under the traditional Medicare telehealth benefit before COVID was part of our vocabulary. So before that, we had several really kind of stringent parameters in order for telehealth services to be covered. And at that time, it was fairly restrictive for rural health clinics. So in order for any telehealth service to be covered under the Medicare program at that time, the service itself would have to be on the Medicare list of covered telehealth services. That list is published every year when Medicare finalizes the physician fee schedule for the upcoming year. So I was just telling Molly right before this session, we typically see the proposed Medicare physician fee schedule at the beginning of July. So here in the next week or two, I expect a several thousand-page publication in the Federal Register on what changes we might expect beginning January 1 of 2023. And in that, we will see some proposals on services to add to the telehealth list. And really, I expect to see telehealth covered quite extensively in that publication. So we've got, and when we send the slides out, you'll have the link to the list of covered telehealth services now, and we'll also have an upcoming list of proposals here within a few weeks to share with you. So the service itself had to be on the list of Medicare approved CPT codes that can be rendered in the telehealth modality. And speaking of modality, if I'm going to skip down to the bottom of this slide, under the Social Security Act, the law that's passed by Congress, the standard was that in order for a telehealth service to be covered, it had to be rendered through an interactive telecommunication technology. But that term was intentionally left undefined, probably to allow for advancements in technology over time, but also leaving it to the Federal Department of Health and Human Services through rulemaking to define what types of technologies constitute interactive communications technologies through which telehealth can be covered. So prior to COVID, with very, very limited exceptions for certain demonstration programs in Alaska and Hawaii that probably don't affect anybody on this call, interactive communication technology meant live, two-way interaction, audio and visual, real-time communications. And again, that is an agency rule that can change or have certain carve-outs for specific services, but that really was the general default on the modality for telehealth. Really, one of the significant limitations, at least it's seen as a significant limitation now that we've experienced telehealth without this stringent requirement, was the eligible originating sites where the patient had to be located. Now, RHCs, you can see on this list, they have always been eligible to render telehealth in the sense that they have always been eligible originating sites. So the patient can come in physically to the rural health clinic and have a distant site provider from another location deliver that telehealth service. And then as the RHC, you can bill for the originating site fee. And that helps compensate for the overhead expense of, scheduling the patient, checking the patient in, having a physical area and resources to present the patient for the telehealth session. So that was one of the requirements. And you'll note at the bottom of that list, except for very limited purposes, the home of the patient was not an eligible originating site. These were all healthcare settings where the patient had to physically present themselves for the delivery of a telehealth service from a distant site. And then the other significant limitation was the geographic area where that RHC or other eligible originating site was located. And it had to be, I'll call it for purposes of today, a rural area or a healthcare provider shortage area. And there's some really nuanced definitions of what that means. But those two things together, the rural geographic area or healthcare provider shortage area and presenting to an eligible originating site, were pretty significant restrictions to the delivery of telehealth pre-COVID. And then the distant site provider, that's the professional or the group or the entity that is actually rendering the telehealth service to the patient and billing for the telehealth service, not as the originating site like an RHC typically would, but the telehealth service itself. So that's kind of where we were for RHCs pre-COVID. RHCs were limited to serving as originating sites so long as they are in an eligible geographic area, and that the service being delivered by the distant site professional was on the list of covered telehealth services. So as we all know, COVID comes along in 2020, and we have the federal public health emergency declaration. And what that does, if I go back one slide here, some of these things that were defined by Congress in the Social Security Act, meaning Health and Human Services as an agency does not have authority to change the definition of the originating site and geographic areas and the eligible originating locations in normal circumstances. But when we move into a federal public health emergency state or status, that allows agencies like the Department of Health and Human Services to issue rulemaking sort of in that emergency environment on a temporary basis that could potentially contradict what is in the statute itself. But once that emergency status goes away, Health and Human Services no longer has the authority to contradict or supersede what's in the Social Security Act. So with that said, 2020, we enter into a federal COVID-19 public health emergency, and we are still in that PHE status or that PHE state. These are good for 90 days, and they can renew every 90 days. They can be allowed to expire if they are not affirmatively renewed. So this isn't evergreen unless and until it's revoked. It expires unless it's affirmatively renewed by the Secretary of Health and Human Services. And so far, every 90 days since early 2020, that emergency declaration has been renewed at the federal level. And the most recent one was in April of 2022. And that would carry us into July. And I can't remember if it was 14th or 15th. I would have to double check on that of this year, which amazingly is in 2 weeks. I don't know how we've gotten to July so quickly. But so that's a pretty important date for us, July 15th coming up, unless it is allowed to expire. It seems like everything is signaling that will likely be renewed again. Historically, that renewal has come about a week before the expiration date. So probably by the end of next week, we will see something announcing that PHE will be renewed for another, PHE status would be renewed for another 90 days. And I say that I think it's likely to be renewed because the Secretary of Health and Human Services has announced its commitment or its intent to make an announcement 60 days prior to allowing the public health emergency to expire. So when this renewed in April, we were really watching like mid-May to see if that 60-day announcement happened, and it didn't. So all signs are pointing to likely the Secretary renewing that PHE declaration for July that would carry us then into mid-October within the PHE status. Now, this last one in April kind of made me nervous because I said historically that announcement has come about a week before the expiration date. And in April, they waited until about 3 days before the expiration. I don't know why it came so late in April, but I was getting really nervous that we were like 3 days away, and that would have a significant impact on certain flexibilities that would go away immediately when the PHE ends. So I think, we will certainly announce, I'll share with Molly if we see any announcements on the renewal or expiration or what's going to happen in a week or two with the PHE. But while we're still in that emergency status, there have been a lot of flexibilities that have rolled out benefiting RHCs and RHC patients, particularly with respect to the delivery of telehealth services, making them much more widely available and also impacting some of the mechanisms of reimbursement for RHCs that allow you to bill for these in a way that you can collect reimbursement for things you couldn't collect on before. So a couple of things that happened during the COVID PHE. The list of eligible distant site providers of telehealth services expanded. Because remember, RHCs before COVID, you could only serve as originating sites. The patient had to physically come into the RHC and we facilitate a telehealth session in order for the RHC to be involved in the telehealth process and bill an originating site fee. RHCs were not eligible to serve as a distant site provider of telehealth services. But during the PHE, that changed. And RHCs right now can serve as an eligible distant site provider and actually bill for the professional service of rendering a telehealth visit. Part of that is also because at the same time, we expanded the originating site list to include patients' homes within or even outside of rural geographic areas. So that geographic restriction went away. Patients can be at home. So if the patient is at home, in order for the RHC to reach out to that patient, and with the idea that we can reduce, in-person potential exposure, particularly during surges, RHCs had to be added to the list as distant site providers. So now you can serve your patients in that way during the public health emergency. One of the good clarifications that we got as well is that if we have a professional like, let's say a nurse calling a patient incident to a physician or a nurse practitioner's plan of care to check on that patient at home and, Rochelle, how's your blood pressure medication going? Can you take your blood pressure and tell me what the reading was? Are you having dizziness? Are you having symptoms? And so on. Similar to what you might do for an in-office blood pressure check, right? And that's being billed as an RHC visit, but now we're doing it in the context of a telehealth service. And it's done incident to a physician or nurse practitioner's plan of care. We got clarification during the PHE that when we do that and bill it under the physician or nurse practitioner's name and number, that that concept of incident to billing typically requires direct supervision, which means the physician or the nurse practitioner need to be in the same office suite and immediately available where the nurse was when that telehealth service was rendered. Well, things particularly during surges were changing where the physician may be at home, maybe due to an exposure or on quarantine or sick with COVID, but well enough to be able to kind of supervise and be available. Or same for the nurse. Maybe the nurse was at home providing these services to avoid in-person contacts as much as possible. And Medicare clarified that it has always been the policy, even though it had never really been addressed, that direct supervision for a telehealth service can be accomplished through what's called virtual presence, meaning as long as that physician or the nurse practitioner supervising the nurse is available to intervene during the telehealth session, that would meet the requirements of direct supervision during a telehealth visit. We also, on that list, if we go back again to this link on the list of covered telehealth services that's kind of identified by CPT or by HCPCS code. On that list, some of the services that are eligible to be rendered via telehealth, the Department of Health and Human Services modified their definition of an interactive communications technology system to allow audio-only services for certain types of visits. So we have really seen that expanded in the area of mental health services being rendered as audio only. And I'll talk a little bit more about rules regarding mental telehealth services and audio only in just a minute as well. So with respect to your RHC providers, a couple of changes or clarifications that have come out during the PHE is that the providers rendering a telehealth service as the distant site provider, they can do that from their home as well. So let's say Dr. Marting, is quarantining at home because of an exposure or a contact or testing positive, but is still well enough to provide care and provide services. We can do that still with the provider at home and not physically located in the RHC without registering Dr. Marting's home as a practice location on the Medicare 855 enrollments. I'm going to put a little star there because what we don't know yet is after the PHE goes away, I anticipate this model of providers, having like a half day at home dedicated a work from home day sort of for providers to render telehealth from those locations. Whether that's going to require enrollment of the provider's home as a practice location with Medicare on their 855 enrollment, or if the rule that's in place now allowing them to continue to bill under the location of the RHC will continue. So to be determined on the logistics of how that may work after the PHE. And then, of course, we've had a significant expansion of the types of services that can be rendered via telehealth during the public health emergency. And I'll be interested to see in a few weeks when the proposed physician fee schedule comes out, if anything has changed on this. But the current plan or the current policy is that expanded list of telehealth services will continue to be available that as an expanded list through December 31st of 2023, even if the PHE ends sooner. At that time, there's a whole bucket of services that typically are not allowed as telehealth, CMS covered telehealth services that are temporarily on that list because of the PHE. And as of January 1st, 2024, would come off of that list, no longer be eligible to be rendered as telehealth services unless information is submitted to Medicare and they become permanently eligible telehealth services. And as I mentioned, that list is reviewed every single year. And if you have services that are not on the permanent telehealth list that you provide, I would encourage you to check out CMS's website. They actually require proposals and requests for the telehealth list to be submitted by February. And I can't remember the date, it's mid-February of each year. They review those and then they're published in the proposed rule in July that we expect to see this upcoming year. Now, last year, they didn't have any that were added to the permanent telehealth list because they didn't receive any requests before the deadline. So that was kind of shocking to me. I think we're all kind of relying on these flexibilities, but that's really something to look at because when you submit it in February and it's proposed in July, the earliest that can become permanently available would be January 1st of the following year. So it is a rather long process to get those reviewed and approved.
Michelle, we do have a question.
Oh, yeah, sure.
First half is, how would you bill if the provider is at home, distant site, but the patient is at the originating site, the rural health clinic, where the provider usually would practice?
Yeah, so that's a good location or good question, because the location then on the claims make it look like the provider and the patient are physically in the same location, right? And whenever they are physically in the same location, Medicare doesn't pay for both an originating site fee and a distant site provider fee. I actually haven't come across a denial with that scenario, but it very well could happen that way. I think what you would probably have to do if there was a denial because it looked like they were being rendered on the same day by the same billing provider, the RHC from the same location, probably have to submit documentation to show distant site physician Dr. Marting was at home that day when the telehealth service was rendered. So they were not billing from the same location. And the other thought on that too is the professional service is going to get billed with modifiers indicating it was telehealth, and that may help distinguish that they were done from different locations as well.
Does it matter if the provider is in a cannot come into the clinic scenario versus a scheduled afternoon telehealth day? Is there a difference?
That's a great question. So the ability for the providers to render telehealth from home, that's a clarification, but that is available That's available pre-COVID as well. The challenge before COVID was that we had to consider whether that was a rare practice location. You know, that they could do this if they were traveling at a conference and they're in a hotel and they need to have a telehealth session with the patient back at home, and they could do that. And because that was a really rare location that they were rendering the service from, they didn't have to register that location as a practice location. But if this becomes every Wednesday afternoon, Dr. Marting's going to be at home to do telehealth service, or something that's more consistent and more regular. Pre-COVID, Dr. Marting would have to submit that practice location in section 4 of the 855 enrollment to show that that was a practice location, and that location, that address, actually translates onto the professional service field. I want to say it's 31 or 32 maybe of the 1500 claim form. So what changed then is not that ability to render from telehealth services from home has been there. The only difference right now during the PHE is the clarification that that does not have to be added as a practice location. And it does not matter pre-PHE, during the PHE, or after. It doesn't matter if the reason that the provider is at home is regularly scheduled. This is just part of the practice patterns and the workflow now. If it's due to a quarantine or exposure, or whether it's COVID related or not, that can be for any reason that they're providing the telehealth service from home.
Thanks.
Absolutely. All right, so I'm going to go through a couple of RHC billing FAQs. There are not a lot of acronyms with my PHEs and my RHCs and my FAQs here, but these were some that I think are really helpful. And I've included the link here to this Medicare frequently asked questions about billing, with an emphasis on changes that have happened during the PHE. And there's a whole section on RHC, FQHC, CAH, coding and billing, and telehealth. And this one document has grown from, I think it started at 11 pages and now it's over 160 pages, I think. So Medicare keeps adding to it, and each Q&A that's in the document, it shows an effective date of when that was added. So you can kind of see when that information first became available. So in this FAQ, it talks about, from the RHC perspective, with this expanded flexibility to be a distant site provider of telehealth services, who within the RHC is eligible to provide the telehealth service to patients who may be at home or in other locations. So it's kind of two-part. Any provider who already renders care for the RHC, so physicians, nurse practitioners, nurse midwives, PA, physician assistants, can all provide telehealth services as well. But then there's sort of this catch-all that any other practitioner, anesthetists, social workers, psychologists, nutrition professionals, who are eligible to enroll with Medicare and bill and be paid by Medicare, they can also deliver telehealth services through the RHC as distant site providers, as well as individuals like nurses who are rendering a telehealth service incident to these professionals' services and plans of care. So that's kind of the who. The what services can be delivered by an RHC as distant site telehealth services. Remember, they've always been able to bill as originating sites. And so I've got the revenue code and the HCPCS code Q3014 for the originating site. With respect to the distant site services, any of those that are, if you were to assign a CPT code to the distant site service, if it is on the Medicare list of covered telehealth services, the RHC can provide it as a distant site service. The trick is that's not exactly how you code it. So that's how you determine if it's covered as an RHC telehealth service. But as we know, for RHCs, it's a little bit tricky on how we code and bill for those. So anything that's on that list, and I think, let me see. Nope, that's our Oh, sorry, I went backwards instead of forwards. I was like, we've seen that slide already. Then we've got the, oh, I know it's on a slide coming up here, G2025, I believe it is, that you would bill for the RHC visit, the RHC service that's being rendered via telehealth. So this is kind of piggybacking on the question that you had from the chat, Molly. Do the distant site telehealth services have to be related to COVID-19? Except this is focused on the patient rather than the provider. So in order for the RHC to render a telehealth service as the distant site provider, does the patient have to be seen for something related to COVID? And the answer is no. The ability of RHCs to render telehealth services during the PHE is not limited to the evaluation, diagnosis, treatment, or testing of COVID or COVID-related symptoms. It's just the fact that this is the COVID PHE that has created that flexibility. Now, there are some instances when it is COVID related that if we add modifiers to the claim, it may waive cost sharing for the patient, but it is not necessary that it be COVID related in order to render the telehealth service to begin with. So here's the question about coinsurance to distant site services. So generally, any coinsurance, copay or deductible under the Medicare program that the patient would have if this were a face-to-face visit are going to apply when the services are provided via telehealth as well. There are some limitations to that, and that's this modifier. I can't see where I'm pointing here. This modifier CS that we can add to the claim whenever the service is to identify the need for COVID testing, COVID-related symptoms. With that modifier, it waives cost sharing. That's how I kind of remember the CS and cost sharing for the member when it's a COVID-related visit or service. All right, so here on the cost report, I thought this was a really interesting question because we're always kind of focused on a claim by claim basis. How do we get these claims out the door and get them paid as RHC visits and telehealth visits? But then we've got the back end on the cost report. So I wanted to include this FAQ. I won't read through it for you, but it gives specific details on how you classify or capture telehealth visits as the distant site provider as an RHC on the RHC cost report. All right, so I want to shift gears a little bit. I mentioned that one of the areas that we see a lot of audio only telehealth has been in the mental health context. So there was a study done by, I believe it was the OIG, the Office of Inspector General, on the use of telehealth during the public health emergency. And what they found at the beginning of that March, April, May of 2020 timeframe is, as we all know, telehealth exponentially increased in utilization. And then it kind of peaked and sort of dropped back down or stabilized for most specialties, except in the mental health specialty, where audio only telehealth services continue to be very popular. And I suspect one of the reasons for that is a lot of other specialties benefit from having audio visual. So if there's at least a component of a physical exam that you can see, where mental health services may be more focused on the counseling and the conversational piece, where a physical exam component may not be maybe as essential as it is in other specialties. But that was sort of the trend. And so we're seeing that, and there's a number of different laws and rules and policies that are affecting how mental health services are provided. I'm going to talk about those and then how they translate to the RHC delivery of those mental health services. So even before COVID, even before all of these flexibilities during the public health emergency for telehealth and RHCs, there was an act that was passed several years ago called the Support Act. And in response to the opioid epidemic, this Support Act expanded the definitions of telehealth under the Social Security Act. So this was by Congress, by law, making telehealth services more accessible to individuals who were being evaluated or treated for substance use disorders or any mental health conditions that co-occur with substance use disorders. And so again, this is a permanent change even before and even after the public health emergency began or will end. And it allowed some of these services to be provided to patients at home permanently. This is one of those limited exceptions before home was an eligible originating site for all telehealth. When it was for substance use disorder or a mental health condition co-occurring with substance use disorder prior to the PHE, we could deliver those telehealth services to an individual who was at home. And now, of course, we can do that even absent this for all mental health services. And that includes when the services were rendered by a rural health clinic. So one of the things that has changed, so you can go back here, or evolved, I should say, is the Consolidated Appropriations Act. I think I have on here 2020, but I've been seeing that it might have been 2021. Year doesn't matter, but expanding that Support Act coverage on a permanent basis to also allow the delivery of telehealth to individuals at home for any mental or behavioral condition, even if it doesn't co-occur with a substance use disorder. That more recent provision to expand all mental health services has become really controversial because unlike its predecessor, the Support Act, when those telehealth services to a patient at home that do not co-occur with substance use disorder take place, we have to have an in-person visit with the patient 6 months before that first telehealth service, and then annually afterwards, with some exceptions. That requirement, that in-person visit requirement at the beginning and that annual in-person visit requirement after the telehealth service does not apply right now during the COVID public health emergency. And I'm going to talk in a few minutes about an extension that it won't apply for a period of time after the public health emergency either. But I sort of anticipate we're going to see some more information and guidance on that in the proposed Medicare physician fee schedule coming out in a couple of weeks, because there have been a lot of questions and a lot of pushback on that. Unfortunately, it's not something that the Department of Health and Human Services has the authority to change, because it was part of the act that was passed by Congress, that initial in-person visit. What I anticipate we may see some guidance or clarification on from Health and Human Services is who can provide that initial in-person visit. Does it have to be a behavioral health care provider? Does it have to be a provider of the same specialty in the same group practice? And some of those pieces of clarification. When the public health emergency goes away and that requirement for the in-person visit is reinitiated, what happens to all the patients that we have been seeing via telehealth without that requirement for the last 2 or 3 years? The current guidance, and I'll say this is very informal, just through an email communication with CMS, is that once our new normal goes into effect at the end of the PHE, you would have to have an in-person visit with that patient before rendering a telehealth service to a patient at home for a mental or behavioral health condition, even if you have been seeing them virtually through telehealth for the last several years. That may be one area that we get clarification on, that if it's an established patient and they've been established for a period of time, there might be a waiver of that in-person visit requirement. We'll see what Health and Human Services and what authority they believe they have to create some of those flexibilities, I think, in the upcoming proposed rules. Certainly something that I'm hoping they open the door for feedback and comments on, that we may be able to ask those questions and get responses in the final rule. So I want to shift gears a little bit and talk about the expansion of the access to virtual communication services by RHCs that came about during the COVID public health emergency. And these are, they're similar to telehealth, but just to make sure I'm not confusing two concepts, these are not actually telehealth services. So even before and after the PHE, these are not subject to originating site requirements, rural geographic area, healthcare provider shortage area, the patients at an eligible originating site. Those rules don't apply. They're kind of quasi telehealth in the sense that they're not services that are rendered in person, face to face with the patient, but they don't fall under the telehealth benefit under Medicare, which is kind of confusing. But we're seeing these virtual communication services that technically are not considered telehealth by Medicare expand, and more of them being created and more of them being covered by Medicare, including when delivered by RHCs. So a few of those, there's something called an online digital exam, and I've got a screenshot of what those codes look like. So an online digital exam for an established patient, this is an evaluation and management type service, but these are happening kind of over a period of time. It's sort of an asynchronous visit or communication that's happening for up to 7 days. So you may be exchanging messages, information, photos of, injuries or rashes or what have you. And then over a period of 7 days, that's kind of the episode, that's kind of the duration of the visit. And within that 7-day time frame, if that online evaluation and management service does not lead to an in-person or face-to-face evaluation and management service within the next 24 hours or first available appointment, then you can report that online E&M digital service. So one of the things I want to continue to emphasize too with RHCs that I think is confusing is these are the CPT codes that kind of describe the service, but RHCs bill for it differently. So when you as an RHC are providing these virtual communication services described by 99421 or 422 or 423, depending on the time, you don't actually report those 3 CPT codes. The RHC reports G0071 to describe the online digital evaluation and management or a virtual check-in type service. Now, these can be reported along with other payable services by the RHC. Now, the ability of RHCs to deliver virtual communication services like an online digital E&M was not available before the PHE, was expanded during the PHE. But some of the extensions that I'm going to talk about in just a minute, this is not among the extensions to different telehealth flexibilities because it's not a telehealth service. So as of right now, and I'm going to put an asterisk on right now because I think what we're going to find out in 2 weeks and the proposed rule will tell us a lot is when the PHE, the Federal Public Health Emergency Declaration goes away, RHCs would no longer be able to provide and bill for these online digital evaluation and management services. And this just shows you what the 2022 payment to provide these services. Again, it's not all at one time. It can be back and forth with the patient, and you're looking at the cumulative time for those communications over a period of 7 days. So all of that is describing what has happened during the public health emergency for RHCs to make telehealth and kind of quasi telehealth services more available to RHCs and to their patients and more easily provided by your healthcare practitioners. So now I want to focus on that last bucket of time, kind of what we're looking at into the future whenever the public health emergency ends. 3 months ago, I was saying that looked like it was going to be in July, and here we are likely facing another 90-day renewal. So I'll stop making predictions and jinxing myself, but whenever the public health emergency declaration goes away, there was an act that was passed, a law as part of the federal finance bill at the end of March, extending certain flexibilities that have been created during the PHE, including some specifically focused on rural health clinics, for 151 days after the public health emergency ends. So what that does to us, for us, hopefully, if we get notification from the Secretary of HHS, like we're hoping to, 60 days in advance of when we expect the PHE to expire, then we have certain flexibilities extended for another 5 months. That gives us about 7 months, advance notice to plan and prepare for the end of some of these flexibilities. But I want to emphasize too that this does not extend all flexibilities. As I mentioned, those virtual communication services, they're not part of this extension. So the ability of RHCs to provide and build these services will go away the day the PHE ends, unless something changes in the proposed rule that's coming out. So what this act that was passed in March did was take some concepts on extending the flexibilities that have been made available during the public health emergency. Among other things, there's a whole section focused on telehealth and making them available. The initial proposal was for 2 years after the PHE, and it went from 2 years down to 151 days, or essentially 5 months. So waiving or changing the definition of an originating site for 151 days after the PHE ends. We will not be limited to rural geographic areas or healthcare provider shortage areas, regardless of who the provider of telehealth services is, RHCs or just regular physician offices. That applies to all telehealth. The definition of eligible originating sites as well is modified to continue to include the patient's home. But here's the other thing. It's actually broader than what we have under the PHE. The PHE added a little bullet at the bottom saying the patient's home, and it doesn't matter if the patient's home is in a rural area or not. This act that passed, extending flexibilities for 151 days after the PHE ends, says anywhere the patient is located could be an eligible originating site. So it could be the patient's home, it could be the parking lot of the grocery store, it could be a retail health clinic. It really opened that up, and it can be anywhere within the United States that the patient is located. Now, in the original proposed legislation, I've gotten a lot of questions from participants in our session about the Ryan Haidt Act, which under the Controlled Substances Act typically requires face-to-face examination of the patient before controlled substances are prescribed via telehealth. And that is a waiver that we have from the DEA during the public health emergency. That agency flexibility, that requiring an in-person visit or waiving the requirement for an in-person visit before controlled substances can be prescribed during a telehealth visit, was part of the proposal, but it did not make it into the final bill that was passed. So as of today, I don't have an indication that once the PHE ends, that flexibility will continue, which suggests to me we are probably reverting back to the pre-COVID rules with respect to having an in-person visit before a controlled substance can be prescribed during a telehealth visit. What it does specifically for RHCs under the definition of distant site providers is specifically called out RHCs and FQHCs, and I'm pausing because I can't remember if it also called out physical, speech, and occupational therapy, but I know it called out RHCs, that RHCs will continue to be eligible distant site providers of telehealth services for 151 days after the public health emergency ends. At that point, it's an agency decision by Health and Human Services on how they define distant site providers. In the meantime, so I've kind of covered what the consolidated, this is the act that was passed, that was finally passed at the end of March of 2022. What, we've got this hopefully 7-month kind of advance notice, right? 60 days before we know the PHE would expire, and then this 151-day extension. In the meantime, we have a lot of federal bills that have been introduced and that are kind of making their way through the how a bill becomes law process that are really focused on the access to telehealth services in rural areas. And one of the themes in a lot of those bills that have been introduced at the federal level is trying to make permanently available RHCs as distant site providers of telehealth services, and to codify that so that's a permanent option that can't be changed by the agency. So my hope is for RHCs at some point between now and the end of that 151-day extension, which is kind of a moving target until the public health emergency expiration date is known, that we can have an act of Congress that might clarify the way RHCs can continue to provide Medicare telehealth services after that time. I also want to address a recent change, or not really a change, something that was made permanent earlier this year. So at the beginning of the public health emergency, we had the concept of we've always had the concept of a mental health visit as an RHC service, right? So at the beginning of the PHE, it was clarified that telehealth services could be a mental health visit under the RHC's definition and benefit of a mental health visit. Earlier this year, effective January 1 of 2022, that was made permanent. So this is kind of confusing because now we have RHCs via telehealth that can be a mental health visit, but that signals to me that we're trying to get permanent changes for RHCs to be able to render telehealth as distant site providers. So that means that the RHC mental health visit could include visits furnished interactive, real-time telecommunications technology, the audio-visual telehealth service. So we can report that as a mental health visit, including, and that may be through audio only if the patient doesn't have access to the video component, chooses not to use the video component, but the provider, the RHC and the distant site professional on behalf of the RHC have to have the ability to use video. It's kind of on the patient's end and their capabilities and their choice not to use the video component in order to have that as an audio only service. So when we're reporting an RHC mental health visit that way as a telecommunications visit, there's sort of some technical billing requirements. And again, this is coming from that CMS FAQ that I'll have a link to when we send the slides out. We use revenue code 0900. The CQ indicates that it is an RHC mental health visit. We add a modifier 95 to indicate that mental health visit was rendered via telecommunications technology. And then if the patient does not have the ability or doesn't want to use video, we then use FQ to identify that it was an audio only telecommunications mental health RHC visit or service. And then the HCPCS code that we report for that is G2025, a distant site telehealth service for RHCs. Now, what the caveat, I guess I will put on that is it doesn't change the fact that when we have a telehealth visit to a patient for mental behavioral health conditions, and after the PHE extensions end, if we deliver that to a patient who is at home, that's a service that would not be covered under our typical Medicare telehealth rules, right? Because the patient's at home rather than an eligible originating site. So when that happens, even though the RHCs can do that as a RHC mental health visit, we would still have the requirement to have an initiating in-person visit within 6 months of that telehealth service. So we'll keep that in mind, and I'm going to be watching really closely in the proposed rules for any changes or discussion about that 6-month visit, because it has been such an area of confusion and challenge that we'll see how that might change or impact RHCs in their delivery of telehealth after the PHE ends. So at the end of these slides, I've got some resources for you too that I think are particularly helpful, are the CMS FAQs, and then some coding and billing guidelines on how you report originating site fees. That'll be on the slides as we send those out to you. So I'll pause there with a few minutes that we have left, and Molly, see if we had any questions in the chat that I can address.
So we actually have a couple. One is for me. There was a question related to proposed legislation and FQHCs. So on the previous slide was, does the proposed legislation apply to FQHCs as well? And then if you wanted to, for that modifier slide too. So we had a question related to the last slide before resources.
Is this the one on the proposed legislation?
Yes, so yeah, it was that slide, and it was related to FQHCs. Does it apply to them as well?
That's right. So yeah, that's a great question. That was the proposed this proposed legislation came out in February that really had the framework on the types of flexibilities that would be extended after the PHE ended. That February bill didn't get passed, but a lot of the basic concepts ended up in the final bill that did get passed. So RHCs included as distant site providers was passed, as well as FQHCs. So the good thing is they're kind of pairing RHCs and FQHCs, and anything that was extended in the final bill that was passed with respect to RHCs was also passed with respect to FQHCs.
Okay, and then the next question was, their business manager shared place of service 10 is not in use due to the PHE. Is that correct? Or should they use POS 10 now? Okay,
that's a great question, and it's going to be payer specific. Right now, it has been really confusing because Medicare is the agency or the body that defines all of the place of service codes. So, place of service 10 or 11 for the provider clinic or 12 for the patient's home. Medicare is the owner of that data set. And Medicare heard from payers that there was a need to distinguish between telehealth services rendered specifically in patients' homes versus other telehealth services. So these other payers asked Medicare, as the owner of that data set, could you create a new place of service code to identify when telehealth services are rendered to a patient's home? So that's when we saw place of service 10 created earlier this year. Medicare right now is not using or requiring place of service 10 to be reported, but we may have other payers, and I want to say maybe our local Blue Cross plan is using place of service 10 or allowing place of service 10 for telehealth services rendered to patients at home. I haven't seen any announcement that Medicare has built that into its coding and billing and claims processing requirements. So it's a little bit confusing because it's on CMS paper and announcements, but it's not a place of service that's used by Medicare yet.
Okay, and I am addressing a question regarding our previous webinars. So a couple of things to remember as we close today's. Thank you, Rochelle, for your time. As usual, please send us any questions to our email, htrc@kumc.edu. I will drop it in the chat. Also, I think I'll get Rochelle to send us that link. Here's our email address. I will dig a little deeper for our FQHC information, and I will get that sent out as well. So those of you that had questions about that, keep an eye on your email. So I think what we will, if it's helpful, we can also include the link for the proposals to Medicare for billing requests that are due in February, if that's okay. I think that might be helpful to include in our.
Sure, yeah, I can send that over to you, sure.
Perfect. Okay, we'll include that. Please keep your eyes open. We will have our next webinar on July 27th, and that will be the physician fee schedule. I did take some notes during today's webinar, so we will do some follow-up and make sure we get that sent out to you shortly. Those of you that did not receive certificates, we will get those to you as well. I will do a little digging on the FQHCs, and then we will get those emails out to you shortly.
Okay,
Thank you, everybody.